Okay. Now it is live.
Yes, yes.
Good morning, everyone. Today we are conducting the 9th session of this Type 1 Diabetes Education Program. We have already conducted 8 very knowledgeable, informational sessions already on Type 1 Diabetes in children. And today we have the esteemed, it's an honor to welcome Dr. Rajesh Khadgawat. And this is the 9th session. And today we have session on the medical emergencies in type 1 diabetes and the critical aspect of healthcare that demands our attention. Friends, medical emergencies in type 1 diabetes such an aspect of type 1 diabetes care that really needs our undivided attention. And the session today will deal us and inform us how to deal with the medical emergencies, the treatment protocols, and also how to be patient in high pressure situations. So I welcome Dr. Ajay Kumar Gupta. Dr. Ajay is past secretary and president of IAP Delhi. Dr. Rajesh Singla. Dr. Rajesh Singla is a London faculty of endocrinology. He is a part of this program, and he is the person who have made this program a reality through IAP. I welcome Dr. Rajesh Singla, and I would request all the delegates to attend this scientific session very, very keenly, because this is going to make difference in clinical rooms and emergencies in the hospital. So I would request Dr. Rajesh Singla to give a kind introduction of Dr. Rajesh Khadgawat and start with today's scientific session.
Yeah, thank you, sir. So I am very privileged to invite Dr. Rajesh Khadgawat for this talk. Dr. Rajesh Khadgawat is my teacher, and whatever I've learned through his blessings. And he's faculty at esteemed AIMS Delhi in Department of Endocrinology. He runs a pediatric endocrine clinic and heads a pediatric endocrine clinic at a Department of Endocrinology at AIMS. He's got innumerable number of publications and the lectures all across international, national venues. He would be talking about medical emergencies in type 1 diabetes, which also include both diabetes ketoacidosis and hypoglycemia. And with this, I invite Dr. Khadgawat to kindly start his session, please.
Thank you, Rajiv. My slides are visible?
Sir, not
right now, sir.
Correctly, I think. You need to share.
Okay, just a minute.
Yeah, sure, sir. They are visible.
Going to the full screen mode. Right, sir.
Yeah.
Great, sir.
So they are visible now?
Yes, sir. Visible, right?
Yes, sir.
And I am clearly audible?
Yes, sir.
Okay, so I start. Thank you very much, Dr. Rajiv and IAP Delhi for giving this opportunity to talk about medical emergency in type 1 diabetes. I would also like to acknowledge contribution of Dr. Rajiv in preparing these slides. Dr. Rajiv has taken this lecture last year, so more or less it's a similar kind of presentation with some addition I have done in this. So I have been given to understand that these are the lectures which has already been done, and then following my lecture there are 2 more lectures on long-term complication and how its future looks like. So we are discussing medical emergencies in type 1 diabetes today. So if we talk of medical emergencies, first thing which come in our mind is diabetic ketoacidosis. It is presumed that every type 1 diabetes more or less suffers at least a episode of diabetic ketoacidosis in their life, whether advertent or inadvertent. So can we prevent the diabetic ketoacidosis, or if we have tried our best, we were not able to prevent, then can we manage diabetic ketoacidosis very well? And the second emergency, which is much commoner than the diabetic ketoacidosis, is hypoglycemia. It's an integral part of type 1 diabetes. Every diabetic patient, he has to have hypoglycemia maybe a couple of times in a day, or maybe in once or twice in a week. But definitely this is a part of management. And in clinical history, when we ask about hypoglycemia and patient do not give history of hypoglycemia, suggests that patient is not maintaining good HbA1c. If you maintain your HbA1c around 6.5 or 7, then likely to cause hypoglycemia. If you are maintaining at 10, then you will never have hypoglycemia. Then uncommon type of emergency, hyperosmolar coma, which is typically described in the adults. And most of this literature is extrapolation from the adult. We do not have much study of hyperosmolar coma in type 1 diabetes. Rest of medical emergencies which we see in adult, like CVA, CAD, CHF, foot, are not commonly seen. Whenever they are seen, it's incidental, not causatively related to type 1 diabetes. Infections are quite common, but management is as per guidelines. So why do we develop diabetic ketoacidosis? This is absolute or relative deficiency of circulating insulin is the main cause. So if insulin is not sufficient, carbohydrate cannot be used. So during that period, for energy production, we have to use some other sources. And because protein is not stored in the body, glycogen is minimal amounts, just 6 to 8 gram in an adult. So finally, fat comes to our rescue, and we use fat for energy production. So whenever fat is produced, at that time, as a byproduct of that, ketone bodies are produced. And the ketone bodies are acidic in nature. And once ketone bodies are produced, these ketone bodies are metabolized by liver and excreted in the urine. But liver has a finite capacity of metabolism of ketone bodies. So if ketone bodies are produced more than that capacity, they are stored in, they are circulate in the blood beyond the capacity what kidney can excrete. So they start accumulating in blood. Since they are acidic in nature, so pH become acidic, and what we call as acidosis in uh, diabetes ketoacidosis. And this acidosis is mainly because of the accumulation of the ketone bodies. So whatever symptoms we are seeing in diabetic ketoacidosis are basically because of the acidosis, rapid breathing, pain abdomen, vomiting, seizures. And if we still do not start treatment, may develop unconsciousness and may lose life also. For inhibiting the production of ketone bodies from the periphery, very small amount of insulin is required. So even if we take that small amount of insulin, that will be good enough to suppress the peripheral production of the ketone bodies. Even if we take 50% of the insulin dose, diabetic ketoacidosis usually do not develop. Diabetic ketoacidosis alone does not mean that blood glucose levels are high. Whatever high levels are there, if we are taking sufficient insulin, it will not cause diabetic ketoacidosis until unless absolute or relative deficiency of ketone bodies, absolute deficiency or insulin appears in the circulation. So why decay develops? Decay develops because of absolute or relative deficiency of insulin. Cause maybe that patient has forgotten to take injection, or there are problems in the pen or pump, or insulin, whatever they have used is denatured, is not functioning. So these are the common causes. But most common cause seen in clinical practice is there is increased requirement, and this requirement is because of intercurrent illness or stress, which may be physical stress because of injury, or this may be mental stress. So if whenever there is any stress or illness, so there is increased requirement of carbohydrate. So to produce, get more and more carbohydrate, whatever insulin we are injecting becomes insufficient, what we call as relative deficiency of insulin. And at the same time, whenever there is illness, there is an increased counter-regulatory hormone like glucagon, cortisol, catecholamines because of stress. And all these hormones, they works against insulin. They inhibit the binding of insulin with the insulin receptor. So there is relative deficiency becomes absolute deficiency. So all these three components are essential part of diabetic ketoacidosis. Either there is a deficiency or there is increased requirement, which is supported by increased secretion of the counter-regulatory hormone. So if diabetic ketoacidosis is imminent, can we treat or can we prevent this diabetic ketoacidosis at very early stage so severe stage can be avoided? This is very much possible, and this is part of integral part of diabetic education. We teach all patients with type 1 diabetes. So even if you suspect diabetic ketoacidosis at early stage, uh, this can be avoided. So how do we prevent diabetic ketoacidosis? So what we call as sick day rules. The first and most important thing is never completely stop insulin. Whatever problem you're having, even if you're having severe vomiting, not able to eat anything, but never stop insulin. Because of illness, there is an increased requirement of insulin. And if we stop insulin, yes, we are inviting diabetic ketoacidosis to develop. Once we detect that yes, there are urine ketones, so at that time, child should be placed in absolute rest, lying down, no muscular activity, because muscular activity will again increase the ketone production and will cause severity of that develop. And during this period, when uh, DKA early stage is suspected, we have to do regular monitoring of blood glucose and ketone. If facility is possible available, we can check in blood, but usually not commonly available. So at home, we can check urine ketones, and every 1 to 2 hourly we can check. And at the same time, we have to increase the dose of insulin. So that will take care of ketone production from the periphery. And the same time, whatever illness we are having, we need to treat the underlying cause, whether it's a fever or vomiting or urinary tract infection. We need to give treatment separately from the episode of diabetic ketoacidosis. Since dehydration is an important component of diabetic ketoacidosis, the first basic step is to adequately hydrate. So we need to encourage oral fluid intake if blood glucose is more than 200 milligram percent, which is very likely we can give carbohydrate free fluids, and if less than 250, we can encourage even if there are carbohydrate in that. We need to avoid the plain water intake because there are no salt. So anything which is containing salt like lime soda or chicken soup or homemade lemonade, salt, sugar, clear broths. So basic purpose is to encourage fluid intake so there is no hydration. And by increasing fluid intake, what we mean is, so the GFR is maintained, more and more urine is produced, so ketone bodies are excreted. So some amount of ketone bodies will decrease just by increasing hydration. And at the same time, we need to encourage them to eat. Idea is to prevent the starvation ketosis, because if we are not eating anything, then we are not supplying any calories. So if you are not supplying, then fat is again going to be used for energy production. So this is what we want to suppress. So regular eating during that period is required. If appetite is not great or if there is nauseating feeling, you can try very small frequent meals, can be taken every 1 to 2 hourly, especially easy to digest carbohydrate like crackers, noodles, rice, yogurt. And if glucose tablets, sweets, candies are available, we can give them to suck that, so that will increase the fluid production from GI tract also. And these food and we can take care of fluid intake, we can at least prevent 50% of episodes of diabetic ketoacidosis which are going to progress. The third essential, if patient is having vomiting, so it would be very difficult to take oral fluid. So what we advise is you give them antiemetics, wait for 15-20 minutes, then starts giving sips of fluid every 2 to 3 minutes. If there is no vomiting, we can increase fluid intake. If there are vomiting with the sips of water, we can use injectable antiemetics. And if vomiting does not subside and we are not able to encourage oral intake, this is the situation where we need IV fluid for hydration. Third and important component of management at home or management at early stage, so we can prevent advanced stage of diabetic ketoacidosis, is insulin doses has to be modified or insulin doses has to be increased. Although societies suggest that blood ketone is to be measured, but at most of the places, measuring of blood ketone is not available. So what we work is on urine ketone, and we know that urine ketone can be easily measured. So if urine ketone is small to moderate, we need to increase the rapid acting insulin. There are many formulas for that. The best and most practical workable is you increase 10% of total daily requirement dose. So somebody is taking like 30 units, you increase 3 units and give rapid acting insulin, and then again observe. If the urine ketones are moderate to large, then we can increase to 20% of daily intake. Suppose somebody is taking 30 units, so we can increase by 6 units, just give a shot of 6 unit rapid acting insulin. You can use analog or you can use regular insulin. And those kids who are using pump, they can be delivered with syringe and pen also, but at the same time that can be used with the pump. During this period, maintain fluid intake and hydration. So if blood glucose is comes to less than 250, then encourage carbohydrate containing fluid for ready supply of energies. We need to understand that if ketone production is large, it's always advisable to transfer to medical facility, admit them for more regular monitoring and for giving IV fluid. At times, if these facilities are not available and we are aware of sick days rules, we can manage at our home, but always advisable to go to the hospital. When we start rapid acting insulin, it may also be possible that we have given more insulin, so there are chances of presence of hypoglycemia. So if hypoglycemia appears and there is absence of ketone, we can decrease total daily dose by again 10 to 20%. But if hypoglycemia in presence of ketonuria, urine ketone, so at that time we do not decrease the insulin. We advise them to add sugary fluids containing simple carbohydrates, so they are absorbed, and try to keep insulin dose same. So when we think of sending to the medical facility for admission, as we discussed that whenever there is a large ketone production, maybe if we measure by stick, if there are 3 plus or 4 plus, or child is not able to take orally, it's always better to admit. If there is no improvement in underlying condition for next 24 to 48 hours, or vomiting is persisting and child is not able to take liquids, then even after 2 to 4 hours, we try our best. And if not, issue not settled, we can think of admission. And is hyperglycemia is continued persisting, in spite of that we have increased the insulin dose, or if there is moderate to large ketones, these are the indications where we need to admit. Or if we see clinical features like fruity odor, altered sensorium, trouble breathe, vomiting, abdominal pain, if these features appears, it's always better to admit the child, maybe for a day or two, so we can give IV hydration, and we can push as much as insulin possible. So now coming back to frank diabetic ketoacidosis. So there are 3 essential components of diabetic ketoacidosis. One is hyperglycemia, any blood glucose more than 200 milligram percent is hyperglycemia, and which is usual situation in all cases. At the same time, we need to demonstrate that ketone production is there or not. So initial stage, there may be only ketone excretion in the urine, but if we have facility, we check in blood ketone, so ketonemia is there. So that is called a ketoacidosis. So these 2 components are essential. And third is development of acidosis. It may be possible that child is having hyperglycemia, ketonuria, but acidosis is still not developed. So once ketones starts accumulating in the blood, by their nature of acidic, the acidosis finally develops. And what we describe, we can do arterial, but it's always better to do venous pH, which is pH is less than 7.3, or serum bicarb levels are less than 18 millimole. We describe as acidosis. And based on the pH level, severity has also been suggested. So one severity we have seen based on the urine ketone. Second, severe, once child reaches to the medical facility, we can have based on pH, we can have severity like mild, less than 7.3, less than 7.2. So between 7.2 to 7.3 is mild. 7.1 to 7.2 is moderate, and severe is less than 7.1. And similarly, we have cutoff for bicarb levels also. So we have done blood glucose, we have checked urine ketone, and we have done VBG. So all three components are there. So this is diagnosis of a frank case of diabetic ketoacidosis. And how do we treat that? So outline of therapy is first resuscitate increasing IV bolus. Then we need to start fluid therapy, which includes deficit as well as maintenance therapy. Third component we start is to prevent ketone production, so give them insulin. And when we have started insulin, their effect of insulin is to shift potassium. So there may be hypokalemia. So we take care of electrolytes. Acidosis, nothing separate is required if renal functions are normal. That will take care of acidosis. Usually resolves on its own, and monitoring is regularly required to measurement of blood glucose and urine ketone, especially blood glucose, because child once have reached to the medical facility and we have made diagnosis diabetic ketoacidosis, there is not much point in measuring ketones repeatedly, because we have made the diagnosis and we have started treatment. Ketone may continue to persist for a maximum up to 1 week also, so will not affect our decision making of ketones. But if ketone increases on measurement, in that case we can look back. And once child is stable, not require more than 24 to 48 hours, and child is stable, we can shift them to again back to their subcutaneous insulin. And we have to be very vigilant to look for if there are any complications of diabetic ketoacidosis or not. So objective of fluid therapy is to restore the circulating volume, so blood pressure improves, replace sodium and water deficits. And by doing this, by improving circulatory volume, there more blood will be going to the kidney. So glomerular filtration will also improve, and that will enhance clearance of glucose and ketones in the urine. Although there are a lot of controversies regarding which IV fluid is to be given, what is the rate of infusion, can it cause or increase the risk of cerebral edema or cerebral injuries. These are the controversial issue. We will see in subsequent slide how do we address these issues. So essential part, first step is IV fluids. And whenever child comes in emergency, if child is uh, alteration of sensorium, we have to deal that. And first thing is to access airway and circulation. So it's always better to secure two IV lines. So by one IV line, we can give uninterrupted fluid supply, IV fluid, and from second we can take blood samples and we can give insulin infusion. So as soon as a child comes, also check for urine pH, renal and liver function test, CBC to look for any infection, evidence of infection, albumin, calcium, phosphate. HbA1c can be done, will not help in any way at this point of time once we have diagnosed diabetic ketoacidosis. In severe cases where pH is less than 7, cardiac monitoring may be required in very severe cases, severe acidosis, but not usually required in all of these cases. So as soon as child comes to you, make sure that airway access is there, they're secure to IV line, take samples for all these investigations, and just check for presence of infection. So once we have taken blood sample, the next immediate step is resuscitation fluid. For child who are volume depleted but not in shock, so early stage of dehydration, we need to give volume expansion. This is given by 0.9% saline or normal saline, calculating 10 to 20 ml per kg, infused over next 20 to 30 minutes, and this will restore the peripheral circulation until unless severe stage tissue perfusion is poor. In that case, we can give more IV fluid, maybe up to 20 ml per kg. Always crystalloid, no confusion. At any point of time, we will never use colloid. Clinical estimates of volume deficit, physical examination, vitamin C may not be that accurate in suggesting that. So we assume that mild decay is 5%, moderate decay is 7%, and severe decay 10% of dehydration. And all of you are very well aware how to correct dehydration. There are many formulas with that. We can use that. First thing, immediately as soon as they come, give them resuscitation fluid, 10 to 20 ml per kg infused over 20 to 30 minutes. And once we have given that, then we need to start deficient fluid replacement, which may be by 0.45% half saline or full saline, or we can use ringer lactate also. So fluid therapy, it includes both deficit as well as maintenance requirement for 24 to 48 hours. All children, whenever blood glucose starts falling during management of diabetic ketoacidosis, there is further decrease in the vascular problem. So we need to check that. Urinary losses usually routinely not added to the calculation of circulation of replacement, the calculation of replacement fluid. We need to do careful monitoring of fluid intake and output, which is essential to ensure the positive fluid balance. There is some issue whether we need to calculate by present weight. So should we need to give more fluid in obese? So this is calculation similar, both obese and non-obese. No additional fluid is given in obese children. Hyperchloremic acidosis usually do asymptomatic, resolved spontaneously. Just if not, then we can use ringer lactate, which will help in correcting acidosis, because lactate will be broken and generated to correct the IV fluid. So just giving example of one New England Journal of Medicine trial, very good trial published a couple of months back. So this trial was carried out to decide is there any effect of infusion rate or type of IV fluid. So what they have included is all children were less than 18 years old. Diagnosis of diabetic ketoacidosis is blood glucose, high blood glucose, pH less than 7.25 or bicarbonate less than 15. So these children were randomized. So they were randomized between 2011 to 16. This was done in 13 emergency department. And this was 2 by 2 factorial design to compare the hydration regimen. And the effect of rehydration rate and fluid sodium content on the neurocognitive outcome, whether they are at risk of development of diabetic cerebral edema during the episode of decay, or is there any effect of memory or IQ recovery from the decay was evaluated. So they used two type of fluids, 0.9% saline. Half of the patient were given 0.9% of saline and half of patient received 0.45% of saline. And they used two speeds. So those who received 0.9% saline, they half of them were undergo fast and half of them were given slow speed. So half speed was replaced deficient fluids plus maintenance, which were given over 12 hours, and rest of the fluid was given over 12 hours. So 24 hours, they have given complete fluid deficit. And in the second group, the similar calculation were carried out over 48 hours. And both of these groups have 0.5% and 0.9% saline. So there were 4 groups. So results of this trial showed that neither the rate of administration nor the sodium chloride content of IV fluid significantly influence neurological outcome in diabetic ketoacidosis. So it's suggested that if you want to use 0.45% or 0.9%, you can use fast or slow regime. There is no significant difference, although it was seen that those who develop clinically apparent brain injury were more in rapid hydration group, but this was again statistically not significant from. So important message which we have received from this trial is use any fluid 0.5 or 0.9%, whether you go for fast or slow, that can be decided again guided by the renal functions. The renal functions are good. You can use fast also, and there is lack of causal association with type of fluid and rate of fluid administration and diabetic ketoacidosis related brain injury. So essentially tells you can use. Once we have started that, the second component we have to take care is serum potassium. So if at the time of starting treatment, we have to collect a serum sample, potassium sample, and if potassium is less than 3.5, means child is having hypokalemia. So we need to start potassium supplementation at the time of initial fluid bolus. We will not give insulin till the potassium level comes more than 3.5, because we know that once we start insulin, it will shift potassium from the extracellular to intracellular, and will again worsen the hypokalemia, which may be very dangerous for the heart. If potassium levels are normal, 3.5 to 5.5, we start potassium replacement. At the same time, we start insulin also. And if potassium is high, more than 5.5, we hold back potassium supplementation till we show the clear urine output is documented. There is no renal impairment. If urine output is there, we can again start in that. Sometimes potassium measurements are not easily available. We can use ECG for help to show that whether there are hypokalemic or hyperkalemic changes. Not a good modality, can be used if not available. Starting potassium concentration should be like 40 millimole per liter, with the maximum we can give is 0.5 millimole per liter. It continues every 2 to 4 hours, and this potassium replacement should continue IV fluid therapy till we continue IV fluid therapies. Once we stop IV fluid, we can stop potassium also. And if hypokalemia persists despite rate of maximum potassium we can give, then rate of infusion, IV infusion, has to be reduced, because this will produce the intravascular hypokalemia. So we need to take care of potassium once we have started fluid. Second is we have to take care of potassium, and based on the basal, we have to take this action. Now come to insulin therapy. Once we are sure potassium levels are normal, we need to start insulin. So before starting insulin, we need to give adequate amount of hydration. So usual dictum is delay insulin therapy by maybe by 30 minutes to 1 hour after giving IV fluids, and then start insulin infusion in a dose of 0.05 to 1 unit per kg per hour. And this is regular insulin or rapid acting insulin can be used. The common formula which we use is we dilute with 50 units of regular insulin with 50 ml of normal saline. So it comes to 1 unit, 1 ml, and then we decide how much we have to give by insulin infusion pump. Dose of insulin remains stable for at least another few hours, or till we find that there is pH has come to more than 7.3. Previously, when we were a student, there was standard teaching that you give first insulin bolus and then you give maintenance therapy, which is not a practice nowadays. And IV bolus insulin should not be used because it can precipitate shock by rapidly decreasing osmotic pressure and can exacerbate hypokalemia. So not to be used. So start with a regular insulin infusion, and before starting that that tubing should be flushed with the insulin solution before administration. Otherwise, for a small child, if there is a long length of tube, so he will not receive insulin during that period. So better to flush that tube and then start insulin infusion. We have started and still we are not finding improvement in our biochemical parameter. We can further increase the dose of insulin. We can double the dose of insulin and again look for another 3-4 hours. If there is no improvement, we can further increase the dose. There is no set fixed formula, maximum dose of insulin we can give. We need to revert these biochemical changes. For less severe diabetic acidosis, we can use lower doses of insulin as well. And to prevent an unduly rapid decrease in plasma concentration hypoglycemia, once blood glucose level falls to 250 to 300 milligram percent, we start 5% dextrose. If we do not start 5% dextrose, then we cannot give more insulin. To give more insulin to suppress the ketone production, we start 5% dextrose. So one arm we are giving 5% dextrose, other we are giving insulin. So by this calculation, we can give more and more insulin, plus 5% dextrose will provide calories that can be used for recovery. If still biochemical parameter do not improve, we can reassess child, review insulin therapy. There may be infection or errors in insulin preparation, or we might be using ineffective insulin. So if we are not seeing improvement, we can change vial of insulin as well. Sometimes it's possible that there are no facility for giving continuous IV administration, or at a center like primary health center where IV insulin not possible, we can still use subcutaneous insulin, or perfusion is poor, we can use IM insulin. So if we are using rapid acting analogs, we can use hourly or 2 hourly because short IFF is less. General guidance is 0.15 unit per kg every 2 hourly, and this dose can be reduced to zero point 0.1 once we see the blood glucose has started decreasing. And we can use regular insulin, since regular insulin has longer half-life. So we can use every 4 hourly, and then based on the blood glucose levels, we can increase or decrease. Still child is not improving, we can increase frequency. So in place of 4 hours, we can give every 2 hours or 3 hours also. But this is not usual situation. In maybe 1 in 100 or 1 in 1,000 cases, you may see giving so much of insulin in child is not improving, where we can use these. Acidosis management, fluid insulin replacement reverses acidosis. Insulin stops further ketone bodies production, so there are no more ketones produced. So whatever there in blood, they will be excreted because GFR has improved, urine output has improved. So nothing specific is required. Treatment of hypovolemia will increase the excretion, and if there is persistent acidosis, in spite of our all efforts, we need to check whether we have given insufficient fluids, or there is infection or sepsis, or incorrect preparation of IV insulin. Control trial, I'm not going into detail, have shown that there is no clinical benefit of bicarb admission. Bicarb therapy may cause paradoxical CNS acidosis, myocardial suppression, rapid correction of acidosis with bicarbonate causing hypokalemia. So always not tried. In very severe cases where pH is less than 6.9, we can think of using bicarbonate administration. Once we have continued these treatment, child usually becomes stable in 24 to 48 hours, fully conscious, start taking orally, vomiting subsided. So this is the time, maybe 24 hours or 48 hours, we shift them back to their subcutaneous and oral intake. So first is to introduce the oral fluids, and we see that that is well managed. There are no vomiting, and mental status is normal. They are able to tolerate sips of clear fluids. Bicarb is more than 15. So at that time, we can shift back to subcutaneous. To prevent rebound hyperglycemia, first subcutaneous injection should be given 15 to 20 minutes if we are using rapid acting insulin, or maybe 2 hours before if we are using regular insulin. So this should be given before stopping insulin infusion. Once we have given subcutaneous insulin, so after that time, then we can stop insulin and shift them to multiple subcutaneous insulin injection. And basal insulin can be given if child is still receiving intravenous insulin infusion. Complications of DKA is not very usual in developed countries. Death rate is almost negligible, less than 1%. In developing countries, especially facilities were not that developed, we may see complications, death in the range of several injury in the range of 3 to 13% from one series, but again not very usual if severe acidosis is not there. Permanent severe neurological sequelae resulting from DK-related brain injuries are very, very infrequent. If hypovolemia persists for longer, there may be renal tubular damage or acute renal injury, which is common with severe acidosis. But again, this recovers, and during that period may have severe hypophosphatemia. Serious complication, most important CNS complication is cerebral edema, which develops during the course of decay. So we will see in subsequent slide. Other complication, DVT, pulmonary embolism, aspiration pneumonia, pulmonary edema, is if child is not fully conscious. In that case, we can think of these complications. So cerebral edema is clinically overt cerebral edema is seen in less than 1%, but if we define cerebral edema by CT scan, so almost 100% of children will have some amount of cerebral edema, but which is not clinically evident or not important. Once cerebral edema develops, mortality rate is very high, and if cerebral edema develops in any child, this will develop within 12 hours of starting or treatment. sometime may be delayed for 24 to 48 hours, but after 48 hours, whatever problem is there, it's not because of cerebral edema. So who are at risk for developing cerebral edema during the treatment of diabetic ketoacidosis? Those who have severe hypocapnia at presentation, severe acidosis, their BUN is increased at presentation, the severe deficit bicarbonate treatment is given for correction of acidosis, especially children less than 5 years, or there is a marked early decrease in the serum's effective osmolality, or there is rapid change in serum sodium concentration. These are the factors which increases the risk of development of cerebral edema. So how do we identify? The most common and important presentation of cerebral edema is persisting headache or worsening of headache. Once we have started treatment, there is no reason for that. Or if vomiting is persistent, or vomiting which was not there initially, now there is a recurrence of vomiting, there is bradycardia, there is obtundation of neurological status, excessive irritability, increased drowsiness, incontinence, specific neurological signs which are quite rare. Denoting as brain herniation, which is very uncommon, or there is decreased oxygen saturation. Once we have suspected diagnosis by CT scan, presence of papilledema may give some indication, but again not diagnostic of cerebral edema. So once cerebral edema is developed, we initiate treatment as soon as condition is suspected. Even we cannot wait for confirmation of diagnosis. So first thing we need to do is reduce the fluid rate administration by third. If persistent features are there, we can use mannitol 0.5 to 1 gram per kg IV over 10 to 15 minutes, and repeat after 30 minutes to 2 hours if there are no initial response. In place of mannitol, we can use 3% hypertonic saline also, elevate the bed end to 30. So by gravity, there is some reduction in cerebral edema. Sometime impending respiratory failure, so intubation is not required, and cranial imaging, once treatment has started and worsening, it's always advisable to do. But if facilities are not available, on clinical presumption of cerebral edema, we can start treatment. There's nothing worse is going to happen with use of, even if we give a small amount of mannitol or hypertonic saline, but if it's cerebral edema, it will definitely take care of that. Hyperglycemic hyperosmolar state is more common in type 2, not frequently seen in pediatric age group. We have not suspected or diagnosed any hyperglycemic hyperosmolar coma at AIIMS New Delhi in last 20 years. So this is so uncommon. Diagnosed when blood glucose is more than 600 with arterial pH more than 7. Bicarb is usually normal. Serum ketones are usually absent or sometimes maybe very small. So this usually develops where there is reduced oral intake of fluid and some amount of insulin is taken. So this insulin will prevent ketone body production, but markedly reduced oral intake will cause severe dehydration. The dehydration in hyperosmolar coma is much, much higher in comparison to the diabetic ketoacidosis. And effective serum osmolality is more than 320. They present with obtundation, or seizures, which is seen in approximately 50% of the cases. Treatment is not, treatment has to be started immediately, but mortality rate is very high if there is hyperosmolar coma, but not to worry in pediatric age group, it's almost unknown. So coming to from decay to hypoglycemia, this is the real scenario, whether to call it emergency or not. This is part and parcel of type 1 diabetes, but this is life-threatening, more life-threatening than diabetic ketoacidosis, because single episode of hypoglycemia may cause seizures and may result in severe morbidity or mortality. And especially if, very young children where they cannot express clearly, there are high risk of hypoglycemia based on the blood glucose level. This is measured by the capillary blood glucose by glucometer. So if less than 70, which is required for all hypoglycemia, but between 54 to 70, it's a level 1. 54, less than 54 is level 2. And less than 54 and third party assistance is required for the recovery from the hypoglycemia, what we label as severe hypoglycemia or level 3 hypoglycemia. So who are at risk for development of hypoglycemia? What are precipitant? What events precipitate a episode of hypoglycemia? By mistake, if we have taken excess insulin or we have taken normal insulin but we have not consumed food, and after taking insulin, child is running, doing exercise, walking, so that again precipitates if child is in sleep. Or alcohol intake in type 1 diabetes, not common in our situation, but nowadays with change of social scenarios, sometimes type 1 take alcohol also. So if they are taking alcohol, there are more chances of hypoglycemia. So what are risk factor if there is hypoglycemia unaware? So where management changes, they are at high risk. Any child who has history of previous severe hypoglycemia is clearly at high risk, and in these cases we have to monitor their blood glucose regularly, and we can think of not going too strict in diabetes control. And with the long duration of diabetes with possibility of impaired hypoglycemia awareness, again there it's a risk factor. If there is comorbid conditions like they also have celiac disease, Addison's, hypothyroid, psychological distresses, so these also increases the risk of hypoglycemia, and if these diseases are there, we have to be very cautious about hypoglycemia. Symptoms are not very usual. Child can present with any symptom in the morning with hypoglycemia and change of symptom in the evening also. So which is again maybe tremors, trembling, anxiety, nervousness, palpitation, sweating, dry mouth, hunger, pallor. So these are the neurogenic symptoms. We have neuroglycopenic symptoms, means there is less glucose is supplied to the brain. So there is abnormality of function of the brain, mentation, irritability, confusion, difficulty in thinking, speaking, ataxia, paresthesia. These are the feature. But important point to highlight here is there is no fixed symptom of hypoglycemia. These are the usual symptoms. If you think that any child is looking abnormal, he was absolutely normal 5 minutes back and now is vacant stare and is not responsive, we can think of hypoglycemia, immediately do blood glucose. So as soon as hypoglycemia is diagnosed, confirmed, then immediately we take treatment. We give 15 gram of simple carbohydrate, and best is to give 3 TSF of glucose, which is the ideal replacement, and then wait for 15 minutes and check again. If it's still low, repeat glucose, and if it has improved, then we can give something to eat. So best is in adults, we give 15 to 20 gram of glucose. Extrapolation of that, so we calculate dose of glucose in children is 0.3 gram per kg. So it's 30 kg child, it comes to 9 gram, and 50 kg child, it comes to 50 gram. It's it's the best treatment. And if not available, we can use non-glucose sugars, but they are not as effective as sucrose or fructose and may require 2-3 times higher doses. They will take time to relieve symptom because sucrose has to be digested in glucose, then glucose will be relieved. But at all point, avoid any food stuff which is containing high fat and high protein, because there are certain regions we'll see in subsequent slides. So once symptoms are over, 15-20 minutes, check again, give them 15 to 20 gram of carbohydrate snack. If food time is near, we can give food also. Children are very particular about eating chocolate during the episode of hypoglycemia. It's always better to avoid, because first it contains sucrose, which has to be digested, will take some time. It contains fat, which delays gastric emptying, so there is late delivery of food to the duodenum. It contains good amount of protein, so protein is also insulin secretagogue, so it may further aggravate or make out rebound hypoglycemia. And at the same time, it's delivering extra fat, which is dense in calories and not required in these patients. So best option is to give glucose. If we do not have glucose readily available, we can use like table sugar, we can use this common tablets of Polo or Poppins, which contains very minimal fat. Glucosidase inhibitor use is not common in pediatric age group, but if somebody is using that, so in that case, if we give sucrose, symptoms will not relieve, because alpha glucosidase inhibitor will inhibit digestion of glucose. So this is we have a simple language prevention of hypoglycemia. We have written in patient's language, where not only for patient, we have information for relatives also. So if patient becomes unconscious, what you have to do. Best option is, if it available, we can give glucose, but at times glucose is not available. So in severe hypoglycemia, best is recombinant crystalline glucagon. Available best option. Dose is 1 milligram for children weighing more than 25 and 0.5 for children less than 25, given subcutaneous as we give insulin. There are some side effects, induces nausea, vomiting when they are regaining consciousness. Efficacy wise, is effective in only those who have adequate hepatic glycogen. Less effective those who are prolonged fasting or extremely poor glycemic control before the onset of hypoglycemia, because glycogen is exhausted. Glycogen, the determinant of glycogen is sufficient amount of insulin, which is not there, so sufficient glycogen will not be there, so glucagon may not be effective. In hospital setting, we can give IV glucose, which is the best, better than glucagon if facility is available, or we can use glucagon. If we are using IV glucose, dose is 2 milligram of per kg of 10% dextrose, and maximum we can give up to 5 ml of per kg. It's always advisable to avoid 50% glucose, because it's a very viscous solution, may cause sclerosis of peripheral veins. Rapid administration can increase the risk of hyperosmolar cerebral injury, so better to avoid 50% glucose. So this is, we are coming towards end. So diabetic ketoacidosis, it's totally a preventable diabetic emergency in life of type 1 diabetes. If we can educate child and about the taking a step for prevention of diabetic ketoacidosis, even if it has developed at early stage, there is adequate hydration, carbohydrate intake, fluid intake, dose modification, continuous monitoring, we can prevent development of severe diabetic ketoacidosis. And once developed, resuscitation, fluid replacement, insulin, and potassium. These are the 4 cornerstones of management of diabetic acidosis. And at the same time, we have to be watchful for development of complication, especially cerebral edema. Hypoglycemia, it's important to avoid hypoglycemia, but totally non-avoidable. So can be easily managed if we have educated patient very well for symptoms and management of hypoglycemia. So this is all I wanted to convey. And if there are any questions, would be happy to answer that.
Thank you so much for, sir, for such an elucidative and complete knowledgeable talk. Now session is open for question and answer. Please send your questions to the question box, please. So, sir, while we are waiting for more questions to come, how would you advise, if I ask you, how would you advise using glucagon injectable? Do you advise people to keep glucagon at home, or do you think it is not practically possible?
Yeah, one is ideal answer. Ideal answer is yes, every diabetic patient should have a glucagon. But problem with glucagon injection is there is short expiry date. Expiry date is always less than months. It's costly. You may not use for a year, and then you have to. I'm audible. Hello.
Hello.
I am audible.
Yes, sir, you are audible, sir.
Yeah. So, but if we have educated child well, especially once child become unconscious at home, we have trained parents how to give glucose. We have seen in our experience that even without glucose,
Yeah, you are, sir.
So, I'm audible.
Yeah, you are audible, sir.
Yeah. So,
yeah, you are.
So in that case,
Right.
they can easily manage. seeing our financial status of our patient, a costly injection, short expiry may not be useful always, but ideally, yes, if they can keep that, increase your confidence level that if something happens, we can use. So ideally should be used. So there's one question: what should be the rate of insulin to start? 0.05 or 0.1? Is there an effect of sudden fall of blood glucose, and does it have an effect? Yes. So this is the ideal situation: 0.05 to 0.1 unit per kg. So if you are seeing a child less than 5 years or 6 years, you can use lower doses, and if child is more than 5 years, you can use higher doses. This is a range. You can use uh, dose of insulin in this range. If as soon as it started and within 1 hour you see that there is a rapid fall in blood glucose, then you can reduce it to 0.01 if you are using infusion pump. And rapid fall of glucose, yes, will have first and most important effect is then you would not be able to give more insulin. So our aim is to give as much insulin as possible in 24 hours. If blood glucose is falling, so we have to slow down, we have to stop insulin. And if blood glucose falls less than 250, start 5% dextrose, so we can give more insulin.
Right, sir. I think there are no more questions. So I invite Dr. Mukesh Verma for closing remarks, sir.
Yeah, am I audible, sir?
Yes, you are audible, sir.
Thank you, sir. Thank you so much. It's my heartfelt thanks to Dr. Rajesh Khadgawat. So your experience and expertise has made this scientific session very informative, and I'm looking forward that everybody has learned today to manage the medical emergencies. And my sincere thanks to Dr. Rajiv Singla also, the man behind today's show, and Delhi IAP office for providing the logistics in the background. And my sincere thanks to all the participants, because it is your involvement and eagerness to learn that make the program like this very success. And I wish you happy learning in the coming session also. And I would like to thank the team Speed and Delhi IAP because it's their initiative both together come to make this educational program, and it's great going, and it's very successful. And I encourage everyone, all the participants, to learn more and more about type 1 diabetes in coming years. It's going to be a big help for everyone. And lastly, I again like to thank Dr. Rajesh for such a wonderful session. Thank you, sir. Thank you so much.
Thanks a lot.